Our next presentation is by Dr. Marina Zakaria. Dr. Marina is a teaching assistant of pathology at Faculty of Medicine, Luxor University, and her presentation is entitled The Uncharted Territory.
Good morning, everyone. I am blessed to participate in this great event, and many thanks for Dr. Muhammad Kamal for giving me this chance. Our case under title Uncharted Territory. I am Dr. Marina Zakaria, teaching assistant of pathology, Faculty of Medicine, Luxor University, and our case under supervision Dr. Muhammad Kamal, Director of Pathology Lab, Consultant Pathologist at Shefa Al-Orman Hospital, Luxor, Egypt. Starting with clinical data, 67 years old male presented to Shefa Al-Orman Hospital by constipation and bleeding per rectum of 2 weeks duration and progressive course and not responding to medical treatments. Colonoscopy revealed sessile polyp about 55 cm from anal verge and another circumferential bulboidal mass 6 cm from anal verge, causing narrowing of the lumen, extending to rectosigmoid area. Both were biopsied and for histopathological evaluation. Grossly, the first biopsy from the sessile polyp was one tissue piece measured 0.5 by 0.6 cm. The second biopsy from the circumferential obstructing mass was multiple fragments collectively measured 1.3 by 0.5 cm, both all embedded. This is H&E from the sessile polyp, which is diagnosed as hyperplastic polyp. And this is H&E from the circumferential obstructing mass, which show sections from colonic wall with focal ulceration filtrated by tumor tissue formed of malignant cells arranged in nested pattern with poor attempts of glandular formation. These cells exhibited marked polymorphism, hyperchromatic nuclei, prominent nucleoli supported by desmoplastic stroma. This is a picture of an infiltrating adenocarcinoma, but is that straightforward diagnosis? The morphological features isn't straightforward toward the diagnosis of colonic adenocarcinoma, as we see nested pattern, abundant eosinophilic cytoplasm, no mucin, minimal dysplasia, and no necrosis. To confirm, pancytokeratin, CDX2 were requested. Tumor cells were strongly positive for pancytokeratin and focally positive for CDX2. Is that straightforward diagnosis? Is that a conventional adenocarcinoma although CDX2 focally positive? We requested cytokeratin 7 and cytokeratin 20, which show focally positive cytokeratin 7 in tumor cells and totally negative cytokeratin 20, which is abnormal in colonic adenocarcinoma. Back to clinical, radiological, and laboratory findings. PET-CT show enlarged prostate with abnormal FDG uptake and SUV max 8 and elevated serum PSA level. Expanded immunohistochemistry panel include NKX3.1 and PSA were requested. This is a picture of NKX3.1 at low power. Tumor cells were strongly nuclear staining for NKX3.1. And this is PSA. Tumor cells were strongly positive for PSA. So the final diagnosis was adenocarcinoma of prostatic origin infiltrating colonic wall up to the mucosa and presenting with colonic obstructing mass. After MDT discussion, which ended with recommendation of transrectal ultrasound-guided biopsy from the prostate. This is a biopsy from the prostate at the low power, which show malignant growth formed of sheets of closely packed acini with cribriform pattern lined by polymorphic malignant cells showing hyperchromatic nuclei and prominent nucleoli involving 100% of the submitted material. GATA3 in NKX3.1 PSA were requested in transrectal ultrasound guided biopsy from the prostate and show negative GATA3. Strongly nuclear staining for NKX3.1 and positive for PSA. So diagnosis is prostatic adenocarcinoma, Gilson score 4+4 = 8, WHO grade group 4, occupying 100% of the submitted material. About prostatic adenocarcinoma, it is a slowly growing tumor that metastasizes commonly to the lung, bone, and liver, but rare to the rectum, presenting at the diagnosis by distant metastasis in 8% of cases. Rectal invasion by prostatic cancer was found in 4% of patients during autopsy. Presentation at superficial level can be deceiving, as we were initially in this case, presenting with obstructing rectal mass, prostatic adenocarcinoma with distant metastasis to the colon or the rectum is associated with poor outcome, even though the outcome of other prostatic cancer is good. Take-home message: the presentation with rectal mass with bleeding per rectum isn't always primary. Chronic adenocarcinoma, prostatic adenocarcinoma should be excluded in old age males. Correlation with clinical and radiological laboratory findings is always mandatory. This is references and case reports. Happy Pathology Day and thank you.